As I say, it was a multi-company project, and it's still reporting this, but the initial audit suggests that the difference between 2008 and 2009 is about £365,000 of reduced costs in emergency medical admissions. They're still auditing what the medicine sales have done. I know that they have gone up, but significantly about that, the medicines management team and finance are involved in the project setup, and their words, we are happy to invest to save the money in secondary care. It's better for the patients, it reduces the burden on secondary care, and it fits strategically with what we're trying to do, which is to manage people in the community. So there was quite a forward thinking, I guess, let's invest now to save later. I have no idea whether that kind of thinking is still going to be easy to do in the new environment where it's sort of do less with less. But, we're on that journey as well. The final one is, I guess, more of a pure reputational one, about putting patients very much at the centre of decision-making around how services should be provided. You don't need to read this. The line, the black writing along the bottom is very much about the patient-defined steps in a treatment pathway. We've got this live at the moment in breast cancer down in Bournemouth and Alzheimer's. And what you see there, we use a core competence of ours, which is sort of discovery interviews. So it's a marketing technique to understand from patients what it is that was important to them as they went through a treatment pathway. The blue bars are where those bits map to what the NHS provides. What the blue line at the top is, it's a score of how important that step to the patient was to have good performance in that step. The yellow line is what they got. This is dummy data, so don't read too much into that. What this enables you to do, though, is to, where you're overperforming against that, you can potentially dial down what you're doing and take the resources associated with that and put them, if they're transferable and movable, into other bits of your pathway in order to improve the patient experience. The patients love this, particularly the breast cancer patients. They don't feel medicalised by a piece of research. It's not about chemotherapy and radiotherapy. It's about helping other people who will come through, which is massively important for cancer patients. The clinicians and the managers in that service have loved it because they've got a robust way of thinking about how they're going to provide, how they're going to put patient views right at the centre of the services that they're going to be providing. And that's really important in this new world of getting your service commissioned. It's been brilliant for us because we have found out more about the patients that use our medicines, and where there is a gap, it provides greater opportunity for us to partner with colleagues in the NHS. So 3 sort of examples there, I hope, that sort of demonstrate the kind of thing that we can do and what that explicit benefit is. These are the masterclasses that we've got coming up. They're all very different. I should just mention the bottom one, Pfizer colleague, that is not a sales pitch. That is about the learning that we have generated as a result of pilot work we've done with the NHS in the field of NHS health checks, and how you deliver that through community pharmacy. That's it from me. I hope what you've heard from me is a really passionate commitment to wanting to work differently and better. I don't have all the answers. I hope I've given you some sense of what examples might be. We've got more in the stand. I'd love to hear from you. Great if you've got ideas. If you think it's all hokum and you think you're cynical, I'd still like to hear from you because I'd like to know what to do differently. Thank you.